Thank you for the kind introduction. My name is Simon Wan. I'm a radiologist and nuclear medicine physician working primarily in London, based at UCL. So it feels like a bit of a setup because I suspect a lot of you are not here really to learn about nuclear medicine, although it is an important element of what you do. So for the next half an hour, I have put together several questions. They're meant to be quite straightforward. They're meant to be quite easy. They're not nitty-gritty nuclear medicine stuff. And I hope that regardless of your background, you gain something from this. The questions are mainly about broad principles. So the format of this is going to be several questions followed individually immediately by some answers. Like a lot of things, there's always a short answer to things, and there's always a little bit of a longer answer. So feel free to interrupt. After each question, I'll give a short answer or a long answer afterwards. And if people are interested, we can do a show of hands as well. So first thing first. Sorry. I've obviously chosen the wrong background, so I'm hoping the text would project. So I'm here to talk about diagnostics and therapies. These are commonly available traces in large nuclear medicine centers in Europe. So the question here is, what diagnostic nuclear traces have been mentioned in the EANM guidelines? For those of you who are not familiar, EANM is the European Association of Nuclear Medicine. They've got very informative websites with lots of guidelines, and there are many ones which are particularly relevant for pediatric oncology, in addition to the other ones which are more related to benign pathologies. As I mentioned, these are traces or nuclear agents which are accessible in some ways. It's quite interesting because there was, in my group earlier in the day, there was a spread of geographical location candidates come from, and it is quite apparent that what can be accessed is quite different between different countries. So I'll leave it there for a few moments for people to look through. Okay, right. Are there any traces that are there any traces that are not familiar to any one of you? Okay, all right. Okay, let's for the interest of time, let's move on. So in my practice, I'm quite privileged. We are the local PET center for a tertiary, quaternary pediatric hospitals. So in my normal practice, these are what I consider as common pediatric oncological indications. Brain tumors, neuroblastomas, and sarcomas and lymphomas are commonly seen in my practice. Starting from brain tumors, there's an EANM guideline about what PET traces can be used for brain tumors. So F18 FET stands for fluoroethyl tyrosine, carbon 11 methionine, F-dopa. They are basically amino acids analogs. We know that FDG glucose is not particularly useful in the brain because of high cortical metabolic activity. So although FDG can be used and has been used to highlight areas where there could be particularly high-grade components to the brain tumors, people have explored amino acids traces as alternatives to variable success. And again, it depends on where you're working from. Say, for instance, where I work, I wouldn't have access to carbon 11 methionine. Maybe Cambridge does in the UK. Likewise, F-dopa, it's quite costly in the UK. I'm not sure what it costs in the other European countries. FDG obviously is on the tap. But there is a European guidelines talking about brain tumors. Right, neuroblastomas, another relatively common indications for us. There is an EANM guideline talking about imaging of neuroblastomas. And apart from the usual I123 MIBG as the bog standard traces, people have tried different things, again, to variable success. EANM considered a few of these traces, PET traces, as standard. So FDG is a widely available tracer with no need for introduction, and it is routinely used for what's considered MIBG negative neuroblastomas. Somatostatin receptor tracer, so here is, I've particularly chosen a slightly unfamiliar one. Dotatate is the often seen tracer, but there are different chemicals or ligands which binds to somatostatin receptors with variable affinity to receptor subtypes, and Dotanoc is one of them. The EANM guidelines considered the somatostatin tracer and F-DOPA as routinely clinically available, although I must admit we don't use it ourselves. And on top of that, there are up-and-coming research tracers. So F18 MFBG is increasingly being used in the research setting. It is basically an MIBG analog, but with a F18 radioisotope attached for PET imaging to potentially give superior imaging results. And F-DOPA is an L-DOPA analog, again, for neurotransmitter metabolisms. So moving on, these two other categories, sarcomas and lymphomas, do not have specific European guidelines within nuclear medicine, but extensively people have used FDG, needs no introductions. Congenital hyperinsulinism, I'm not sure if that really should, I don't know if it falls into the remit of oncology, oncologists, but it is, to me, it's my understanding is that it is a proliferative disorder. Children and babies are born with abnormal pancreatic, potentially lesions, either in the diffuse form or the focal forms, which have important treatment implications depending on the form. Basically, these kids, sorry.
I wonder if everyone is aware about EANM guidelines. Do you know what they comprise? Do you know how they've been developed?
Does anyone know? That's a good question. So EANM stands for European Association of Nuclear Medicine. They have a lot of guidelines which are published in their websites. Normally, I've been involved in a couple. Normally, they have a group of international experts. They circulate the guidelines to national societies before they are signed off. They're usually published in nuclear medicine journals, I must admit. Well, it is difficult. I particularly chose this because, as I mentioned earlier on in the session, it is quite apparent that what is available depends on multiple factors. So without trying to be controversial, I thought EANM is going to be authoritative enough.
I think it's excellent because it helps with uniformity, of course. People can use these EANM guidelines, and I think maybe some of the radiologists may even be quite jealous of all the guidelines that you already have. So it's maybe good that we are aware of it and that we can refer to it in our protocols.
Yeah. Okay. All right. Thank you, Renike. Well, in the interest of time, let's move on. These tracers are, again, unfortunately depend on market forces. So, for instance, F-DOPA is actually quite a useful tracer. Anyway, I can tell you more about it if we have time at coffee times and whatnot. And of course, towards the end, if you're using nephrotoxic chemotherapy, within the UK anyway, the isotope GFR is still the gold standard test. And if you are thinking about taking away kidneys or radiotherapying the retroperitoneum, you may wish to do split renal function assessment in the form of DMSA or renograms. So there are a number of tracers which I haven't referred to, and if anyone's particularly interested, I can go through them in coffee time. But as I mentioned, these are available tracers for different purposes. Okay, all right. In the interest of time, let's move on. So the second question I have is, what are the typical radiation doses to children from PET-CT, FDG, and a planar I123 scans? Again, I'll leave that there for a few moments. It is important because we're dealing with the pediatric populations, and the principle has always been for radiation protection, we should always be using as low as is practicable the ALARA principle. Does anyone know what MSV stands for? Okay, right, so it's millisieverts. It's a measure of radiation dose. So to give you a bit of a clue, these are the references. It has been quoted that a transatlantic flight flying from Europe to America, a return trip would get you, just because you're that bit closer to the cosmic radiation, you will get an additional radiation dose from simply the cosmic radiation of 0.1 millisieverts. A chest CT is said to be around 2 millisieverts, and a chest X-ray is said to be about 0.02 millisieverts. Does anyone think that it's going to be hundreds? Okay, all right. Does anyone think that it's going to be 0.2 and 0.1? Okay. So it is going to be somewhere in between. Now, the long answer to this is that let's go through a detour. So one of the principles I want you to take home is that now we're into the era of hybrid imaging, i.e. we often do either a PET CT or SPECT CT or PET MRI. We haven't got a SPECT MRI machine yet. But when it comes to radiation doses coming from the investigations, it is important to realize that if you're using CT as part of your hybrid imaging, your CT dose increases with the coverage, and it increases per exposure. So in here, I've got a PET CT covering from vertex to the feet. So all this, every inch of your body length, you can't see the cursor, but every inch going from top to feet, you're adding extra radiation because you're blasting the CT. Okay. On the other hand, the nuclear medicine components, i.e. either the gamma emitting tracer or the SPECT or the PETs you care to use, the radiation dose is delivered by the injection itself. So hypothetically, if you're to be doing an FDG PET scans, you give the FDG injection, and for whatever reason the patient or the parents doesn't want to go through with it, the whole of the FDG radiation dose is already incurred. Whereas if the patient doesn't want to go through with it, you're saving on the CT radiation dose. If you are to be doing something fancy like dosimetry, again, I won't have time to go through that, where it requires multiple SPECT CT. In this case, for instance, an MIBG scans here, I've got a planar MIBG scans. To do formal organ and lesion dosimetry, you need to be doing multiple SPECT CTs. You've already given the therapeutic agent. That radiation dose is given right from day 0. But every SPECT CT you do, the CT component adds an extra radiation dose. Okay, so the principle to take home is that the CT is incremental, whereas the nuclear medicine dose is given straight off. Now, SNMMI is the International Society for Nuclear Medicine, and if there is a joint guideline with EANM, the European ones, talking about FDG, and also EANM has a pediatric dosage guide to tell us how to scale down the injected activity from the nuclear medicine component. So we generally go by weight somewhat. If you talk about a typical child, the radiation dose from an FDG PET dose is around 5 or 6 millisieverts, around 3 CT chest worth. In addition to that, if you're doing PET CT, you're adding another 5 or 6 millisieverts. So actually, an FDG PET scan is about 10, 11 ballpark figure. It is of interest. Some of you have access to PET MRI. So if you're doing a PET MRI examination, for the fact that you're not using that CT, you're saving, some people claim that you're saving around 40 to 50% of radiation dose. You've got the PET information, you've got the MR information, you don't need a CT, and you save on radiation dose. So that's an uncontroversial advantage of PET CT. So going back to this here, a ballpark figure of an FDG PET CT for your understanding is around, therefore, it's around 10 millisieverts, whereas for a planar MIBG, i.e. if you just want this picture, which is the box standard, for SIOP scoring, you don't want any of the SPECT CT. The radiation dose for an MIBG scan is around 5 millisieverts. Okay. Is there any question before I move on? Okay. So next question is, what are the typical imaging times for nuclear medicine studies? We are talking about just the acquisition, the time that the patient needs to lie on the scanner. I've chosen these questions because I think they are important questions for most of you who are going to be in the roles of referring clinicians who may need to explain to the patients what to expect. So how long do you think a whole body PET CT would take compared to a planar scan and a SPECT CT scans? Again, in the interest of time, does anyone think it's going to be 5 minutes for a PET CT? Okay. Does anyone think it's going to be 1 minute for a planar MIBG? It's low quality. Oops. All right. Okay. Okay. This is more realistic for current technology. Okay, I stress this is current technology, and I jumped the gun a little bit because I go straight to the answer against what I said in the beginning. So on a typical scanner nowadays, a whole body PET CT, simply from the acquisition, so that you remember the patient would have to come up here, faster for 6 hours, inject it with FDG and lie down for 60 minutes before they get onto the scanner, and they need to lie down on the scanner for about 15 minutes. A planar MIBG actually takes about half an hour. Okay. On the other hand, a SPECT CT, it scans in bed position. So if it was a 5-year-old, I've got a 7-year-old daughter, I suspect we would be able to cover her from head to thighs over 2 bed positions, and each bed position on current SPECT CT scanners will take about 20 to 25 minutes. So to cover a whole body, we probably need 2 fields. And if you're talking about a teenager, if you are trying to replace, if your center is trying to replace whole body planar MIBG with whole body SPECT CT, which gives you the 3D advantage, you may need to have 3 fields. And so your scanning time would then end up going to be around the ballpark figure of an hour or so. And of course, like I said, there's always the long answer to this. Okay. So for this question, this is what I want you to take home. The uptake time are the time that you need to wait for the pharmacodynamics of the tracer to work, i.e. for how long you have to leave the patient to cook effectively until you start scanning. Beyond that, it is you can swing things several ways round. How long do you need to scan for? Yes, there's the guidelines, but there are multiple factors at play. Like CT and MR, they've got their own constraints. And with nuclear medicine technique, if you are happy, if you're able to, if you want to gain from one domain here, you have to give on another domain. Conversely, if you are happy to forego some of the image quality, you can allow to scan faster. So for instance, if you inject a high dose, if you're happy to give a high dose of radiation, okay, I don't care about radiation dose, then actually you can, because you've given a high dose, you can actually afford to scan quicker, and you will still get the same image quality. On the other hand, if you say, well, image quality, radiation dose is important for me and for my center and for my patients, then for the same image quality, you would need to scan for longer. On the other hand, if you are happy to forego image quality, if you say, well, actually, look, I don't care, should I swing it the other way around? I want really good image quality because I want the confidence. Then you may want to both up your radiation dose as well as your scan time. On the other hand, the thing in the middle, as you can see, is the thing that you don't really have very much control about, the hardware and the software, because it is constrained obviously by current technology, which is also a moving baseline by itself. These pictures and tables come from a slide I was giving a talk for a different purpose. And that showed when I first started practicing, back in 2013 as a consultant, we caught the end of I caught the end of an older scanner. You can see here, compared to the new scanner we have, we were scanning for much longer, we were giving high dose, and yet the image quality is quite poor compared to what we have on the left-hand side, which is the newer scanner. So even within that short time frame of about a decade or so, you can see hardware and software improvement has meant your bracket of the triangle has improved. Now this is not commercially available yet. This is a total body PET scanner, which was manufactured in collaboration between an American center and a Chinese manufacturer. Basically, what this is showing is you inject FDG. The scanner is sensitive enough to track the FDG as it goes through the cardiovascular system and into the lungs. You can even see the heart beating. The scanner is said to be about 40 times sensitive compared to conventional scanners. With this, the claim is therefore that if you inject a standard dose, you can actually get a total body PET CT within 1 or 2 minutes. And therefore, you can actually get a total body PET CT without potentially needing GA, or it makes a difference between needing a general anesthesia or not. Right. Okay, moving on. If you are to need to use general anesthesia, this comes from one of our own local surface evaluation. Everything else being equal, this uptake time is the same. In the middle, the scan time is the same, but actually time on scanner, simply for needing your anesthetic team to set things up, shorts up dramatically. So the point here I want to make is therefore that it is that it has very important resource implications if you do your assessment carefully at the point of referral. Does this child need a GA or not? Because your nuclear medicine colleagues are not going to like you, because actually it takes, for that time they can do 3 scans instead of 1. There are other manipulations we can do. Say, for instance, in our center, we tend to do the whole body sweep for planar MIBG, but if your child is not compliant enough, you may be able to get exactly the same information by doing spot views, 5 minutes here, 5 minutes there at a time. So going back to this, the point I want to make is that there are many variables to the image acquisition, and therefore, if you are stuck, talk to your radiologist or nuclear medicine physicians to see if there is anything that they can do and get you the pictures that you need. Okay, if I'm correct, I've got another 5 to 6 minutes. So moving on to therapies. How many members of staff do we need to actually be giving radionuclide therapy, do you think? Here I was scratching my head. I was learning to give therapy from my colleagues. That's me scratching my head there. Okay. And then obviously I've blanked out the faces of some of my colleagues. A related question. Can you identify these items which are important to radionuclide therapies? Well, I suspect actually, does anyone know what this is? Yeah. Okay.
Thinks it's the shield.
Yeah, that's a shield. What about the silver trolley? What's in there? Hmm? Yeah. So in the radionuclide therapy rooms, it looks very complicated. So basically, if you swing the metal trolley around, this is the gadget inside. It looks really complicated. The wiring, the plumbing looks very complicated. But what it is it's basically it's nothing more complicated then, well, giving radionuclide therapy for unsealed sources, the liquid form, is nothing more than actually, you know what, just bung it in. It's just liquid. All these gadgets have important purposes, though, because for the ALARA principle, we want to limit the dose to the child, to the staff, as well as to parents. So therefore, these gadgets are there only to make sure that the staff are not overly exposed. We can do all the setup and effectively do the infusion remotely. And in doing so, we also limit the potential for contamination. If you can imagine, in theory, and we have done it in the past when this setup doesn't work, we just pick up the syringe and in it goes, right? It's nothing more than that. But basically, all these metal pots are there so that we can just slot the thawed MIBG into those needles and plumbing, so that we can actually just flush the syringes remotely without exposing ourselves too much or contaminating the place. We also need to flush the syringe. Again, I'm really sorry. The burette over there is to basically allow the saline to drop through into the burette for us to be able to flush through the pots which are hidden underneath the metal wells a few times, so that the residual dose is minimized. So in essence, this looks very complicated, but it is there for those reasons, rather than simply just pushing it in. So the white thing is the shield. That's to limit the dose to us. The computer is important because for radiation protection purposes, it's a bit funny because a lot of the patients for MIBG therapy, different treatments would have different constraints, but for MIBG therapies, the child needs to probably stay in for a few days from UK regulatory purposes. A lot of the times the patients are completely well. There's no clinical reason they need to stay in the hospital for MIBG treatment. It is basically they are staying in because we have to wait for the radiation dose level to come down so that they are not irradiating members of general public. It's a bit silly, but it is what it is. And there are those constraints to member of general publics that they should be exposed to, beyond which we'll have to do something about it. So the computer is there to entertain the child, as well as the Legos. The drinks are important. Basically, the drinks are there to flush out the excess activity, to reduce the bladder dose, if it was MIBG, say, for instance. In terms of number of people involved, at UCLH, we routinely go up as a medic and clinical scientist pair. But if you count up the wider team, there's a lot of people involved. There's at least a dozen to make sure that all these complicated things are lined up. So if we are doing a therapy, we want to scan, the nurses needs to be there to be giving antiemetics, the radiopharmacist, the pharmacist need to prescribe and prepare the things and so on. So it is a good teamwork, basically. So I hope you enjoy the quiz. It's not really groundbreaking or exciting, but I hope that it's broad brush enough to keep you interested and it's relevant to your practice. So the take-home point from me really is that nuclear medicine has been, it is a relatively, it is gaining pace, should I say. I think it's fair to say that it's gaining pace in terms of the number of tracers available, therapeutic agents available. The scanner equipment is somewhat exploding. So although things doesn't seem to have moved in the last few decades, I think things are moving and it's gaining pace. And as a result of that, I've stayed towards the general principles instead of doing the specifics, because things may well change and things may be different from your countries to what we have in the UK. And particularly for you as the referring clinicians, having a sense of radiation dose and the details about the procedure so that you can explain to the patients, I think is quite relevant. Thank you very much for your time in that case.
Thank you, Simon, for this very interesting insight into nuclear physician medicine. I think you brought up topics we should all be aware of as a pediatric oncologist referring patients to the nuclear physician medicine departments. Any questions to Simon or comments? Let's start here.
Okay, so thank you for a really good talk. It's basically a simple question, but which situations would you say that you would not recommend an examination? For instance, patients with kidney issues or any other general thoughts on that? Where it's contraindicated?
In terms of diagnostic tests, I can't really think of any, really. I think, in fact, we do sometimes get referrals, not just for pediatric patients, but simply, like you mentioned, renal function. The agents we use, it's a very minuscule amount. We are latching onto the sensitivity of radioisotopes and the compounds, and therefore, in terms of pharmacological effect of the amount of substance that we give is very, very minimal. So there's no contraindication in terms of liver functions, renal functions, unlike CT or MRI contrast.
Yeah, I was just wondering, the biggest headache we have by far is getting the children to lie still, for this especially if they're small. Do you have a recommended sedation policy that you use in London, or have you got any thoughts about that? It's something our radiologists advise on often.
So as I mentioned, I think there are many ways of reducing the scan time in those circumstances. In terms of, for us, we have a black and white approach. We either go for GA or we don't, and we don't really for pediatrics. The intermediary often is having some allied health profession called the play specialist. So we are fortunate enough to have these allied health professions who are quite used to working with children. They use a number of techniques, mostly distractions. So we can project, say, for instance, DVDs on top of the ceiling, so when the patient lies down, they can watch a film. They can have a teddy bear or whatever distraction that the play specialist sees fit to try and distract the children. When it's baby, sometimes we time it to after feeding, so some kids may just fall asleep naturally, well, some babies may just fall asleep after being fed. So there are several techniques like that. When it comes to sedation, as I mentioned, for us, we don't actually use it ourselves, but it's a preference more than anything else.
Last question.
Thank you very much. After the kid has the examination, can we be exposed to it? How near can we be? The nurses, the doctors, everyone?
There is no, well, it's somewhat analogous to how long is a piece of string. So there are, in the UK certainly, and I suspect in a lot of countries, there are those constraints beyond which the staff member needs to have extra monitoring or extra maneuvers done. But they generally are very high, and realistically, we don't really come close to that sort of levels. In terms of radiation protection, the principles is time, distance, shielding. So in terms of time, for instance, if we are going up for giving radiotherapy, there are a number of us, we tend to rotate round, so each of us don't get, it's not the same person going up to give the therapy all the time. Those we kind of vaguely mentioned, we can play around with the dose. And distance and shielding. So that's why all these complicated gadgets to achieve the same effect of, you know what, just bung it in. And that's to keep that distance away. Ultimately, we will get a dose, but hopefully with respecting those time, distance, shielding, the doses to staff, I'm hoping to say that it's minuscule, really. Although, yes, we have colleagues who are very concerned, understandably so. It's very bad of me to be saying this, but a lot of our less learned, in terms of nuclear medicine techniques anyway, a lot of our radiographers actually in main radiology, the radiographers who do CT and MR who are not familiar with nuclear technique, they don't like us sending the patient from nuclear medicine to them, i.e. they always want to, if the patient needs a CT or MRI and also a nuclear medicine technique, they always wanted the patient to actually go to them first before they come to us. But again, as I said, if you respect those things, actually the dose is, in the common sense, is not that much.
Okay, thanks a lot, Simon, once more for your talk.